So I'm going to talk about three studies that presented at ASCO this year, 2 or 3 weeks ago. There was some, at the end of the talk, I'm going to talk a little bit more generally because this only covers adenoid cystic carcinoma and salivary duct carcinoma. So I'll talk a bit more generally for 5 minutes at the end about what else is going on for other salivary gland subtypes. So this is the trial of Serenity, which is the drug that's quite similar to Apatenib in patients with adenoid cystic carcinoma. The second one is the study of Axitinib and Avelumab. So that is, Axitinib is also quite similar to Serenity and similar to Apatenib and similar to Lenvatinib. They're all the same sort of class of drug, really. So Axitinib plus Avelumab. Avelumab is an immunotherapy in adenoid cystic carcinoma. And the third study is of a HER2 targeted therapy. It's a trastuzumab, which is like Herceptin. It's just a similar drug to Herceptin and a chemotherapy drug, docetaxel, in salivary duct carcinoma. And so just as a word of introduction, I mean, I think here most people know this, but the challenge, what makes these studies so impressive in their own right, salivary gland cancers in general are very rare. So Sam Rack, who some of you will have seen, one of my research fellows who presented to the group at the end of last year, put together this exploding pie chart for me, which is from the Public Health England Cancer Registry data. So it's reasonably reliable data, and over a 4-year period, they captured 3,500 patients in the cancer register with salivary gland cancers, and you can see all the different subtypes. So adenoid cystic carcinoma being around 21% in this series. Salivary duct carcinoma, that the third study is looking at, is only 1% of salivary gland cancers. And then the study of salivary duct carcinoma patients, it was those that expressed this HER2 marker. Well, that's only about 1/3 of all salivary duct carcinoma patients. So it's 1/3 of 1% of this small subgroup, of this small group of patients. So this is what we were just talking about, the real challenge in getting carbon ion studies and proton studies and radiotherapy studies and the data, randomized data in this patient population is really difficult. So that's the first thing. The second thing just to say about these numbers, this is a surgical series. So, most patients with salivary gland cancer present with resectable disease and then have surgery, many of whom are cured. And so these numbers are all for surgical patients. They aren't the same as the numbers I see, who are predominantly those with recurrent disease. And I'll show you in the last bit of the talk, actually, how the numbers are for my group. And the other thing to say is, this is from around 2012. I think this cancer registry kind of cohort. So one type of salivary gland cancer called secretory carcinoma isn't even included in this data because it's a relatively new entity. So it was first described around 2010. Secretory carcinomas are one of the they're leading the way really with our salivary gland cancers in terms of drug therapy development. But they're not even included in this cohort, so it's difficult to know exactly how many of some of the subtypes there are. They were probably classed as either adenocarcinoma not otherwise specified, there would have been a bit of this group, or they may have been misclassified as a cynic cell carcinoma previously. So that's a bit of a background, and I know you're quite familiar. So to talk you through the first study, so this is the Serenity study. A bit of context to it. So about 2 or 3 years ago, there was a study of a drug called Apatenib. And Apatenib and Serenity are very similar drugs. Apatenib was available in China. It was a single center study in China, basically. So this drug, different companies developed it across North America and South Korea. This study took place. There is also data for Lenvatinib, which is a similar drug, for Axitinib, which is a similar drug. And this is the plot here. And I'll spend a few seconds just talking you through this plot. This is the plot for Lenvatinib. I've got a few plots like this in the presentation. So when we look at patient responses to drug, we sometimes present them this way, and this is individual patient level data. So the patients were all treated with Lenvatinib. They all had adenoid cystic carcinoma. 32 patients. There was no randomization to something else in this study. And this black line here is the zero change. And if the line goes up, that says the best response is tumor growth. And if the line goes down for that patient, the best response is tumor shrinkage. And then it tells you the percentage change. And so you can see here, these patients had tumor shrinkage. These patients here had tumor growth as their best response. And this cutoff here, this dotted line, is at the 30% mark. And it may sound arbitrary, but in clinical trials, we always use this 30% cutoff to define response. So the response rate is this group here, which is 5 of 32 for lenvatinib. Although it may well be the case that some of these patients also had benefit. If they had tumor shrinkage of 10 or 20% that lasted for some time, that would arguably provide benefit as well. But that's where this response rate figure comes from. It's this group here. And there were 2 studies of lenvatinib, and the response rates were 12 and 15%. There's kind of a scientific logic for those that were at some of the previous talks. We've talked a lot previously about MIB. MIB is, I won't spend a lot of time on this, and if you're not interested in MIB, you can just switch off for the next 30 seconds. But essentially, most adenoid cystic tumors overexpress this particular gene MIB, and one of the things that MIB does is drives this VEGF signaling, and the drug targets VEGF or VEGF or vascular endothelial growth factor. So there's a logic to this, these drugs being the sort of better option. And this is just an overview to the study. So, compared to all the other studies, one thing to note is there's 80 patients. And these patients were recruited at 11 sites in the US and Korea. So that's one of the largest studies ever in adenoid cystic. It's a really impressive rate of recruitment. They also restricted recruitment, saying patients had to have confirmed disease progression or measurable growth on their scans before they went into the study, and we'll talk a bit more about that in a second actually as to why. So they were treated with this drug rivaroxabanib, and as almost all studies would say, the treatment continued until you either had disease progression, which means tumor growth on the scans over a certain level, or unacceptable side effects. So you stopped if the cancer was growing or if the drug wasn't tolerated. And then this is again this is the results of that study. This is the same plot, or the same type of plot. So it shows individual patient responses for those for those 80 patients. The response rate is actually quite similar to lenvatinib. So if you look at this dotted line again is at the 30% mark, and the partial response rate was 15%. So this is 15% of your whole cohort. So stable disease means neither having progression or response. So it's this whole group in the middle, and 74% had stable disease as their best response, and I'll talk about that again in a second. They then went on to do a couple of other assessments. So most studies assess response in the same way. They allow the local team, to their radiologists are trained to do it, and they assess response. But in this study, and I think this is a strength of the study, they imported all the scans and had a central, what they call blinded independent review committee assessment, a central assessment. The response rate was then lower. It was 9.6%, so it drops from 15 to 9 or 10%. The reason it will change, well, there's different reasons, but one of the most likely reason it changes is if someone's got 10 sites of disease and one radiologist picks 2 and another radiologist picks a different 2, and things, they will change differently, and so the measurements will look different. So you will get a different response. Technically, it could have gone either way, really, in that case, because you pick them at baseline and then you stick with them and follow them through. The other thing is they did look at those that had never had prior treatment. So VEGFRI naive means no previous treatment with lenvatinib or with axitinib or other drugs that work in a similar way. And the response rate in those that had never had previous treatment was higher. I think it was 18 or 19%, 18 point something percent, if it was this untreated. So it kind of depends what group you look at and how you look at it. I think the take home is we're not comparing across 2 studies, but it looks quite similar. This picture looks quite similar to this picture, really, just with larger numbers of patients in it. One of the differences is this study required tumor progression. So if you look here, this again is individual patients being plotted, their response over time. This here is time point 0, which is when they started on the trial. and this shows what was going on before they went on study, and then this shows what happened after they went on study. And so you can see patients, by definition, all of them should have had some sort of tumor growth, defined as normally something new on a scan or something that's increased by 20%. So they'll have either gone up by 20% or they'll have shot up because there's something new, I think. And that's why there's these two sort of groups of patients here. And then, oh, sorry, is there a question there? Sorry, I can't see the screen. I've turned people off.
I can hear someone talking.
Oh, right. I was wondering if someone's asked the question. I've had to turn off the pictures of people. There's no question, is there not? No, I'll carry on. So, yeah, but then what you see is tumor growth and then tumor regression. And this is starting to unpick, okay, those patients that don't fit this category here, but they're somewhere in the middle. Well, maybe there is some meaningful benefit here in this group that have what are classed as stable disease. If things shrink by 10% and then say shrunk down up until 20 months, that actually might be clinically quite useful. So that's their data. So, yeah, and radiological responses can be durable. I mean, this study, only recruited 2 years ago, and then you've got 2 years of follow-up. So there's some patients clearly that get tumor shrinkage that lasts for 2 years, and that's, I think, very beneficial for those patients. In terms of side effects, I think lots of people are familiar with lenvatinib. It's a similar drug with similar expected side effects. High blood pressure. This grey box shows high blood pressure. They call it grade 3. That means you've had to start someone on blood pressure medication to bring their blood pressure down. People don't normally feel ill with that, to be honest, but it's the most frequent significant side effect. Grade 3 normally means you've interrupted the drug. So there's lots of other grade 3 side effects that are kind of 5% frequency. But overall, grade 3 to 4, meaning you've had to stop the drug and do something or admit someone to hospital, did occur in 80% of patients. And around 80% had a dose reduction as well. So, and I think that's what we see with lenvatinib. So I don't know. I mean, it's not head to head. Is this better tolerated than lenvatinib? I think it possibly looks a bit better on these sort of figures, but I think it might be quite similar. Okay, I'll skip on from that because I think I'll risk overrunning. And the other two questions, yeah, I think I touched on this. So defining the best treatment of this type, should we be planning some sort of head-to-head study to compare the two? I don't think we should really, to be honest. I think we're better off doing other studies. And this other question about stable disease, I mean, I think that the study that was just reported has started to address that by requiring tumor progression on study entry, and also by measuring retrospectively what was happening before patients were on drug. You can then start to map out, okay, here's a group of patients that have progression and then stabilization that might be useful. But the only way of really getting it is having some sort of randomized study. So the second study, so this is the same patient group, adenoid cystic carcinoma. But it's a different drug. So axitinib, which is quite similar, plus avelumab. So everyone got axitinib and avelumab combination. Avelumab is an immunotherapy. So it's an immunotherapy plus VEGF study. And the sort of context is there isn't, we need to have better immunotherapies. This plot here is for one previous study of a combination immunotherapy showing, again, I think this was 6% response rates, but 3 out of, oh, it's 10%, is it 3 out of 30? It looks like on that plot. But there's no strong signal from our current standard immunotherapies that have been looked at in adenoid cystic carcinoma. The kind of scientific logic to looking at this combination of axitinib plus avelumab, so VEGF that axitinib targets, although its normal role is in development of blood vessels for tumors, it's also been shown that if it's in the tumor, it's kind of immune suppressive. It causes immune suppression within the tumor. And we know that tumors secrete this VEGF. And we also know that immune cells within the tumor start to secrete it, and it sort of suppresses the tumor anti-tumor immunity. So by blocking VEGF, it actually may well be an immunotherapy rather than a sort of blood vessel targeted therapy. And so this was a single center study, MD Anderson in Texas, it's big cancer center, recruited over a couple of years. 41 patients went in, 7 screen failed, and then another 6 or so, or 6 didn't have sufficient treatment for various reasons. So there were only 28 patients then that were able to be sort of presented, and they were all treated similar. Really, they had axitinib plus avelumab and similar sort of rules. As long as there's no evidence of toxicity or there's no evidence of progression, then they carry on with treatment. And they measured this thing called response rate, again looking for tumor reduction. So I mean, it looks quite similar, to be honest, to the other waterfall plots. The actual number is, round it to 18%, 17.8%. Of patients having a partial response, meaning they cross this threshold, and another sort of 20 or 30% having some sort of tumor reduction. Maybe I'll mention it. They also had information about whether patients have this Notch gene mutation. So in brief, there are almost 2 types of adenoid cystic carcinoma, those with and without Notch mutation, and they do behave very differently. So those with a Notch mutation are much more likely to grow more quickly or spread more quickly than those without. And 7 of the 24 patients, which is 1 in just over a quarter of them, had a Notch mutation, and they were represented on the plot here by an asterisk here, 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 here. And you can see actually, though, patients with and without Notch mutations, so these 2 had Notch mutations, these 3 didn't. So in the response group, patients responded with or without Notch mutation. And then this is, again, the individual plot showing duration of treatment and duration of response. And you can see 3 patients with the arrows were still on drug. This is weeks in numbers here. So this is almost 3 years, 2 years is about this point. So you can see there's, of these 5 patients, 3 of them, which is 10% of your whole group, is clearly getting some sort of meaningful lasting benefit, where the tumors decreased by 1/3 and has stayed down for up to 2 to 3 years. In terms of side effects, it was described that it was considered tolerable. The dose reductions, which I think are a good surrogate for how well tolerated the drug is. So axitinib was dose reduced in 1/3 of patients, and avelumab was stopped in 15%. And actually, if you compare that to the Serenity study, Serenity was dose reduced in about 80% of patients. So it does look more manageable than the Serenity sort of side effect profile. And that's also the case with drugs like lenvatinib. Serenity is similar to lenvatinib. And it met, the study met its endpoint with this response rate. So this is the 3rd study. So this isn't adenoid cystic, okay? This is salivary duct carcinoma. So just bear that in mind. So this is the group that are just 1% of all salivary gland cancers. And in fact, salivary duct carcinoma overexpressing HER2. So 1/3 of 1% of salivary gland cancers. And there is quite good data for drugs that target this HER2 or HER2. So trastuzumab is the other name for Herceptin, and this study is from 2018, where patients with HER2 overexpressing salivary duct carcinoma were treated with trastuzumab and docetaxel, and the response rate, I mean, this is quite different, isn't it, from what we've just looked at in the group in the previous 2 studies. The response rate in this is 70% in the 2018 study, and this is considered a good option really for patients with HER2 overexpressing salivary duct carcinoma. There's also data for these other HER2 targeted therapies, trastuzumab emtansine and trastuzumab pertuzumab. So really the rationale for this study is that this is a different, it's called trastuzumab PKRB. They call them biosimilars. So basically it targets the same HER2 protein, but the drug is made in a different way. And in fact, this docetaxel is also a kind of biosimilar. It's got a different agent to dissolve it. So it's a study that's basically saying we've got new versions of the same drug. Do we see the same effectiveness? I think these are also available in South Korea. The first author was from South Korea, and all the centers, I think, on the list here are from Korea. So that's the sort of context of the study. And so patients basically all had to have HER2 positive salivary duct carcinoma. They were allowed to have other salivary gland cancers that were HER2 positive basically as well, but they would have all realistically had salivary duct carcinoma. And they were treated with, these are the brand names, but this trastuzumab, PKRB and docetaxel. So this was 43 patients looking for a response rate of 40%, even though the data for the other drugs was 70%. And again, they recruited over 2 years. And what they found was it looked just as good, basically. So the response rate of 70%. Stable disease, so far fewer patients in this group having stable disease, falling between these lines here. And then if you look over time, so this is in months, the wording's gone off the legend, but you can see tumor regression seems to happen over the first couple of months, and then it tends to be durable, 12 months, 24 months, 36 months, and that's kind of what you see really with these HER2 targeted therapies in HER2 cancers, HER2 related cancers. Again, it was described as considered manageable, but if you look here about, so AE stands for adverse events, and so side effects basically leading to discontinuation. Just one patient had to stop the trastuzumab drug, which was just 2% or 2.3%, and 30% of patients had to stop the chemo drug. It's what you expect actually with these drugs like docetaxel. But certainly the HER2 targeted drug is very well tolerated. So and let me stop sharing again and screen share, stop share. So, but remember that's a different. So we've done the first two studies were adenoid cystic carcinoma studies. This was a salivary duct carcinoma study. So just remember that.